Are we ready? Okay. So good afternoon, everyone. I hope you're all safe and dry and warm, at least for the time being during this respite. But would like to call the uh, January 10th meeting of the Laguna Honda Hospital JCC to order.
And my name is Mark Morowitz, the Commission Secretary. I will do roll call. Commissioner Guillermo.
Present.
Commissioner Chow.
Here.
Commissioner Green.
Here.
All right, now I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you, Mark. Okay, and would you also call out the items for us?
Sure. Item 2 is the approval of the minutes of December 13th, 2022 JCC meeting.
Okay, thank you. And I have not received any requests for edits or changes. So if I could have a motion to approve.
So moved. Second.
And there is a hand up, and I'll just remind folks on the public comment line that you can press *3 to raise your hand to make comment on any item, and we encourage you to do so when the item is called to make sure you have time that you get your hand up in time. So I see one hand, but and I will start with you. Everyone has 3 minutes. When the buzzer goes off, please know that your time is up. Caller, you're unmuted. Please let us know that you're there.
I am. It's Patrick Manette-Shaw.
All right.
These minutes are deficient, not mentioning that Mr. Morowitz stated on December 13th, quote, there was a comment made about the root cause analysis report, so I want to let you all know that the consultant created that document and turned it into CMS. I want to make sure it's clear to you when that document is all finalized, the document will come to you and will be available to the public at that time, end quote. The RCA was supposed to outline the deficiencies that led CMS to decertify Laguna Honda on April 14th. Laguna Honda and the RCA was to be the RCA was to be the basis for the action plan submitted to CMS on January 6th. Release the RCA now. The minutes also didn't disclose that during closed session, the JCC was probably told about the immediate jeopardy fire response violation Laguna Honda received during the 90-day monitoring survey that was extended, that became an extended survey. Thank you.
Thank you for your comment. I see a few other hands. Caller, please let us know that you're there.
Yes, this is Claude Joseph. I'm a supervisor with SCI 1021. I just wanted to speak on the whole CMS and Laguna Honda issue on the agenda.
I'm sorry to interrupt you. So this is the minutes. The item is the minutes, and you're welcome to comment on the minutes if you can contextualize it in the minutes. But if you're talking about general CMS and Laguna Honda, this would not be. It would be better to talk about that on the executive team report or general public comment, which are the next 2 items.
I apologize. I heard the CMS talk. I thought we were on that item. So I'll wait for general comment on that item.
Sure. And there's no need to apologize. There's no worries. That's my job to make sure everyone's right in the right place. Okay.
Thank you.
Great. Now, next caller, you are unmuted. Please let us know that you're there.
Hi, I wanted to talk about Laguna Honda Hospital. Is this the right item?
This is the minutes from the last meeting, so if you'd like to talk about the minutes and talk about Laguna Honda in the context of minutes, you can do so. But if it's a general comment, you can, the next item is general public comment, and the item after that is an executive report, and both of those are opportunities to make comment on the, in a general sense.
Okay, thank you. I'll wait for that.
Okay, great. So commissioners, those are the only hands that I see. Do you all, I know you all did motions. My assumption is there's no comments on the minutes based on that. I've had a senior moment and forgot already that, that there's no comments or questions from you all. Okay, great. So I'll do a roll call vote. Commissioner Green?
Yes.
Commissioner Guillermo? Commissioner Guillermo, I need to hear you, sorry.
Sorry, yes.
Okay, great. And then Commissioner Chow?
Yes.
Okay, wonderful. Thank you. The minutes are passed, and we can move on to item 3, which is general public comment. And folks on the line, this is a time to talk about anything that's not on the agenda. You can comment about really anything with Laguna Honda, but there are items on the agenda that relate to Laguna Honda as well. But this is time to make your comments. Everyone will have 3 minutes. Let's see. I see lots of hands. Press *3 if you'd like to raise your hand. I will start with in the order I see you. Give me 1 second. Okay. Hi, caller, you're unmuted. Please let us know that you're there.
Yes, this is Claude Joseph, again with SCI Local 10-1. I'm a supervisor with SCI 10-1. I just want to say, look, we've been working very closely with the team at Laguna Honda on this whole CMS and Laguna Honda closure issue. I just want to state the union's position and how we've been working collaboratively together. I believe that we've made a lot of progress on many issues, and I think that management has done their due diligence and make the good faith effort to be transparent on how we're working together. There's been many issues in the past that we feel we've made great progress on, including the discharge issue and creating a mechanism for folks who were forcefully discharged to return back to Laguna Honda. There was the closure issue. With the extensions that we've been getting from CMS, we believe that we're working very well together in order to make that happen. So, however, we do think that perhaps it's not Laguna Honda leadership that needs to work on this, but the support of the commission and politically to see how we can better the process to hire the needed staff to handle this work, because the whole recertification process is presenting basically 2 different type of workload for our members. One is having to do their daily work, the work that they regularly do, and then they have to work through this whole recertification process. And the feedback and the report back we're getting from our members is that, the workload is heavy. So whatever that the commission could do to help hire personnel and do so in a timely manner to alleviate or to remove some of that stress from our members, we think that that'll be very helpful. And we also think that that would solve a great number of the problem that we are foreseeing or we are seeing, because we believe this at the center of all these issues is a staffing issues. But with that said, I think that there's always improvement that could be made on the relationship. But we do appreciate management's transparency with us for the most part. And if the commission could help us in any ways, bring more staff into the hospital to help with this recertification process, SCIU 10-1 particularly would greatly appreciate it. Thank you.
Thank you for your comment. Caller, you're unmuted. Please let us know that you're there.
I am. It's Patrick Lynette Shaw.
All right, you've got 3 minutes.
Thank you. Suddenly, tragically or comically, depending on your point of view, along came San Francisco's Director of Public Health, Grant Colfax, who presented is LHH recertification strategy update to the full Health Commission on January 3rd. Wait, what? Shouldn't the recertification strategy have been developed in May at the outset of the now $23.2 million in external consultant contracts awarded to HMA and HSAG? As in, don't you put the horse before the cart? Colfax's facilities operations and capital projects team focuses on capital projects. What capital projects help CMS obtain CMS recertification? Laguna Honda's planned housing project? What experience is the Children's Oral Health Program Director qualifies Prasanthi Patel to be managing operations for a skilled nursing facility? Colfax's revised closure plan team is led by Terry Dentoni, acting chief nursing officer, and Claire Horton, acting chief medical officer. Neither have skilled nursing or gerontology on the job experience. I just learned today that CMS has not extended a written notice to Laguna Honda to pause the forced mandatory discharges, and so they may resume on February 2nd because CMS has not given an extension to the pause on forced discharges. As far as the capital project, the kitchen floor replacement project at $4.4 million hasn't been scheduled, and I believe the Health Commission has said it is not a required capital project to obtain recertification. You need to tell us what the capital project portion of Colfax's strategy plan is.
Thank you for your comment. Okay, next caller, please let us know that you're there.
Thank you. This is Michael Lyon, Gray Panthers. I'm glad to hear that there's transparency with SEIU 1021 in management, but there has been absolutely no transparency with the public in terms of the action plan, in terms of root cause analysis, and especially the revised closure plan. Everything has been done in closed session. And I have to tell you, I have no faith whatsoever that you guys are planning to do anything other than dither around and do a lot of busy work around the edges, but not attack the main problems of the flow project, the planned closures, the discharges, the bed reductions. None of this. Why has CMS not given an extension, a written extension of the pause? You have completely lost the faith of the people in what you're doing. Thank you.
All right, thank you for your comment. Next caller, you are unmuted. Please let us know that you're there.
Hello. Hello, commissioners. My name is Norman Daleman. I'm a longtime resident of San Francisco, and I'm concerned or urge you to keep the level of new beds in the new facility. So thank you very much for your time.
Thank you for your comment. Next caller, I believe, by the way, Commissioners, this is the last hand I see up. Next caller, you're unmuted. Please let us know that you're there.
Thank you. Yeah, my name's Art Persico, and I'm on the board of the San Francisco Gray Panthers. The SF Gray Panthers call upon the Health Commission to ensure that residents are already discharged by force must be allowed to return. There should be no closure. Funding for existing residents must continue until recertification. There will be no loss of beds in this nearly new facility. There will be no forced discharges of skilled nursing facility eligible residents under any circumstances. There will be no discharge for non-skilled nursing facility eligible residents until safe and local arrangements are made. We demand transparency for the public in planning changes of Laguna Honda policies and operations. Laguna Honda should take the steps necessary to prevent inappropriate, unnecessary, illegal, and unsafe nursing home admissions. SF Department of Public Health must stop the flow project of SF General Hospital patients and return admission decisions to dedicated Laguna Honda Hospital staff who understand how a nursing home operates. SF Department of Public Health and the government agencies above it, including state and federal, must provide sufficient mental health and substance abuse programs and residential beds to give people the care they need. Also, sufficient services must be provided for elders and people with disabilities to stay in their communities where possible. Laguna Honda must be open to all San Franciscans who need nursing home care. And finally, you should take the necessary steps as soon as possible to restore admissions to Laguna Honda Hospital. Thank you very much.
Thank you for your comments. I believe that is the last hand. Let me just check and verify. Yes, that is the last hand. So that's the last of the general public comment. Thank you all very much. I'm going to put down all the hands right now since we're moving on to another item. And we are moving on to item 4, which is the executive team report.
Okay, thank you, Mark, for moving us along. And I know that, Roland, you're prepared to provide the executive team report. So I'll just go ahead and turn it to you.
Thank you very much. Good afternoon, commissioners. Happy New Year. Good to see you in this first meeting of the year. So we'll move forward with the report as presented. I'm Roland Pickens, interim CEO here at Laguna Honda Hospital. Next slide. So as we've shared many times before, Laguna Honda is one of the largest skilled nursing facilities in the country and provides an array of services above any other facility in the country. Next slide. We'll recall the decertification that occurred back in April of 2022. And since that time, we've been working diligently with our staff, consultants, and other stakeholders to make sure we're making the appropriate remedies to come back into compliance with CMS participation. As you know, that decertification led to the potential loss of funding up to $200 million a year to the Laguna Honda budget. However, we continue to remain open and licensed and operating as a skilled nursing facility. Next slide. As I mentioned, we've worked hard to continue to meet regulatory requirements. To that end, we brought in 2 consulting groups that have been with us since the middle of May, working on these recertification efforts. Next slide. You'll recall after Laguna Honda submitted the mandatory and required patient closure plan that required that we initiate transfers to other facilities and discharges. We quickly saw the results of that and were able to reach an agreement with CMS to initiate a pause in that closure plan. And under the terms of that pause that was negotiated back in November, CMS has agreed to continue paying for care at Laguna through November 13th while we implement the terms of the settlement agreement, which we'll talk a little bit more about later on. Next slide. Part of that settlement agreement, one of the main components was that CMS would conduct what they call monitoring surveys every 90 days at Laguna Honda. These are and have been unannounced, extensive, full recertification surveys looking at all elements of CMS SNF requirements. The first of these monitoring surveys actually began on November 28th of last year, where we hosted over 20 surveyors, and that survey lasted about 3 weeks and concluded on December 16th. Laguna Honda staff worked collaboratively with the survey team and has since submitted a plan of correction both for fire, life safety, and emergency preparedness. And we are actually currently in the process of drafting a plan of correction for the other remaining items of that survey. Next slide. So the settlement agreement also required that Laguna Honda engage a quality improvement expert, or QIE, to assess what were the leading root causes that led to that April 2022 decertification. CMS approved Health Services Advisory Group as the quality improvement expert. As the quality improvement expert, Health Services Advisory Group was instructed by CMS to conduct and develop a root cause analysis that reviewed surveys retrospectively going back starting in October of 2021 through April 13th of 2022, the date of the decertification. And it's important to realize that this RCA that CMS required was a retroactive look at what were the conditions that led up to that April 13, 22 decertification. The RCA describes in detail the reasons that the QIE has determined that were behind the identified deficiencies that led to the decertification. They've identified 8 key areas in that RCA, and I will list what those are. Quality assurance and performance improvement, or also known as QAPI. The second area, infection prevention and control. The third area, behavioral health and substance use. The fourth area, medication management and administration. The fifth area, residents' rights and freedom from harm. The sixth area, comprehensive care plans and quality of care. The seventh area, competent staff, training and quality of care. And finally, the last 8th area of emergency preparedness. It's important to note that the theme throughout the root cause analysis is that over time, Laguna Honda somehow became out of sync with the requirements of high-performing skilled nursing homes as established by the CMS skilled nursing facility requirements. Next slide. So as a result of the findings from the RCA, we are working hard with our staff, our consulting partners, and other key stakeholders to realign Laguna Honda with best practice skilled nursing facility regulations. It's important to note that when I gave the dates of that RCA in terms of looking at taking a retrospective look, it's important to note that that look was based on a snapshot of conditions during that time frame of fall 2021 through the summer of 2022. And by no means does it account for all of the work that has been achieved since April of 2022 over the last 8 months. Next slide. Oh, I'm sorry, we can go back to, okay. So a little bit more about the RCA. The RCA was an extensive process undertaken by Health Services Advisory Group as the QIE. In addition to identifying those 8 main areas of root causes that contributed to the decertification. Health Services Advisory Group also assisted the Laguna team in producing an action plan that addresses those 8 areas of root cause analysis. That action plan details the steps that we must take over the next few months in order to remedy those deficiencies and be ready to apply for recertification. You recall early on over the last 8 months, we presented a previous roadmap to recertification. So it's important to note now that this new action plan as part of the RCA, that now becomes our new blueprint for how we're going to accomplish recertification in Medicare, and the milestones associated with that action plan is our new map towards recertification. The proposed action plan was submitted to CMS last Friday, January 6th. It's important to note that while we have submitted that plan to CMS, the plan is not final until CMS reviews and makes any changes or clarifications they feel are necessary. It's also important to note that that action plan that we submitted last Friday, as required under the terms of the settlement agreement, must be fully implemented, all of those hundreds of milestones, by May 13th of this year, 2023. Also, under the terms of the settlement agreement, each month, the quality improvement expert, Health Services Advisory Group, must submit a report to CMS on Laguna Honda's progress towards meeting the terms of the settlement agreement and the action plan of the RCA. It's important to note that the action plan represents a significant facility-wide effort. You heard our union partners relay the concern of their members about there just being a lot of work going on, and it is very much true. All of the staff at Laguna, we are all feeling the effects of just the work that's required, the important work that's required for us to meet the terms of the settlement agreement and be prepared to sit for CMS recertification. A summary of the action plan has been shared with our staff, along with an executive summary of the proposed action plan and milestones. And again, that's proposed because it is not finalized until CMS tells us they have accepted it and that we've made any changes that CMS will require. Before I move on to the next slide, I would also like to address 2 other important issues related to the current status of Laguna. First is our closure plan. As I've referenced before, when we became decertified, we were required under CMS rules to produce a closure plan. That closure plan was presented, previously, and under the terms of the settlement agreement, we needed to revise that closure plan, which to reflect the new work that we're doing under the settlement agreement with the RCA and the action plan. So we submitted that revised closure plan on December 21st of 2022, and we're still awaiting a response on the closure plan as to whether or not that will be accepted by CDPH and CMS. We are also, that closure plan required that those transfers of residents out of Laguna, as you recall, were placed on pause and continue to be on pause through February 3rd. We are also working through the city attorney's office to pursue an extension of that pause. As you can imagine, none of us want to ever return to having to resume discharges or transfers of patients out of Laguna. So we are actively pursuing getting a written response from CMS, actually asking them to extend the pause and explaining to them why we think Laguna is deserving of having that pause extended. You know, we've made many improvements in our organization over the last several months, and we think we have shown and made the case to CMS that hopefully they will approve our request to extend the pause and transfer beyond February 3rd. And as soon as we receive a response, we will keep the commission, the JCC, and all stakeholders updated on the response to our request for an extension. So it's important to note that you know, the transfer, rather the closure plan does have requirements that we still follow state CDPH, Department of Healthcare Services rules. And so again, we are hoping and praying and planning to not have to resume transfers, but if we did, the same rights that residents had still applied, the right to appeal any transfer decisions or requests. But again, we hope to not be in the position to even have to entertain that. And finally, the second other important issue I'd like to address is that of the transfer report related to the residents that had been previously discharged from Laguna and went to other skilled nursing facilities. As you will recall, back in April of 2022, when we were decertified, we were required to submit a patient transfer plan. That was a requirement of CMS to continue our funding. You'll recall in that plan, we strongly advocated that we not have to do transfers. And in fact, that we said if we were forced to do transfers, we would need 18 months to do that in the most expedient fashion. As you also will remember, that 18-month deadline was rejected, and we were forced to implement a 4-month transfer process that led to the transfer and discharge of up to 56 residents out of Laguna. Many of those residents went to other skilled nursing facilities, and of those, there were 12 former Laguna Honda patients who were transferred to other facilities who since passed away while they were still in the care of those other facilities. So the CDPH has shared with Laguna their assessment and review of those 12 former Laguna Honda residents who were transferred and passed away at other facilities. And as a result of their review, on December 20th, CDPH issued 12 citations to Laguna concerning 11 of the former residents who were transferred to other facilities last year and subsequently died while in the care of those facilities, and one former resident who was discharged to medical respite and died after that. It's important to note that the 11 residents who left our care and were transferred to other facilities went to certified facilities that were certified in the Medicare and Medicaid program, and that they remained in the care of those facilities for the weeks and months prior to their deaths. It's also important to note that the review from the California Department of Public Health on what's called a 2567 report did not find that Laguna Honda caused serious harm to any resident and did not find Laguna Honda took any actions that were the direct proximate cause of any resident's demise. However, CDPH did issue 12 what's called Class B citations, And it's important to note that Class B citations are the lowest level of state citation in relation to these transfers. We take this report and those citations very seriously, and we have submitted a plan of correction to the state and are awaiting their response. It's also important to note that while we take their findings seriously, we do not agree with all of the CDPH allegations and findings, and we'll be communicating that to the appropriate audiences. Obviously, we were very saddened to hear and learn of the deaths of our former patients who were transferred to other facilities. But as I've said before, we tried our best to not have to transfer or discharge any residents, but unfortunately, under the terms of the agreement with CMS, we had to comply. And so we recognize that the closure plan imposed by CMS and California Department of Public Health put our staff in a very challenging and painful position, a position we're working to never find ourselves in again, and that is transferring patients to other facilities. We're grateful for the care and support of our staff that they provide to our residents, and we know that our staff are some of the greatest advocates and champions for our residents, and really see many of them as members of the family. Next slide. Okay. So as I'm wrapping up the leadership report, wanted to also just update you on COVID-19. It's still with us. We continue to have a hospital incident command structure set up around COVID-19. Continue to monitor it on a daily basis. That includes both testing of both residents and staff, and making sure we are optimizing resident and staff uptake of the available vaccines and boosters. Next slide. And also, we always share with you admissions, discharges, and expiration data, and you see that here. You'll see back in December, the average daily census was 555, and obviously that count is significantly lower than what we've seen in past years, and that has to do with our inability to accept any new admissions since January of last year, and our continued on hold status of admissions. Next slide. So that concludes most of my report, but I'd also like to mention that further on in the agenda, we have a review of policies and procedures. And there are a lot of policies, and our Director of Quality will share more with you, but it's important to note that many of these policies, the vast majority, are a direct result of the new CMS Phase 3 requirements for skilled nursing facilities. And so we've had to work really quickly and hard to establish new policies, but also revise all of our existing policies to reflect these new Phase 3 requirements. So apologies to the JCC and the Commission for the hundreds of pages of policies and procedures that we have cast upon you, but please know the timing did not align in our favor to make sure that we complete our annual review plus review of these new Phase 3 related policies. In addition, there were questions forwarded to the leadership team from the commissioners on the JCC, and various members of our team are actually ready to provide some responses to those. And I told them I would give them the opportunity to add on to the end of my presentation, if that works for you, Commissioner Guillermo.
Okay, thank you, Mr. Pickens, for that very extensive report on the most critical issues facing us, in addition to giving us a picture of what we hope to achieve not just over the next few months, but really in the future as we reorient ourselves to the skilled nursing facility that we want to become standard with in terms of excellent care and an excellent facility. I'm going to now turn to Mark and see if there's any public comment on the executive director's report before turning it back to the members of the commission and the committee to ask their questions.
Sure. Commissioner, would you prefer to wait to have staff answer the written questions or before or after the public comment? I think you have an option on this.
Yeah, I think actually since they were questions submitted in relationship to the executive director's presentation of his report, why don't we go ahead and do that first and then go to the public's comments and questions.
Great. And Mr. Pickens and staff, if y'all could read the questions so the people in the meeting can also hear the context of whatever the response is, that might be helpful.
Okay, very well. We'll start with the question on the vacancy report. Terry D'Antoni, do you have a question that you can read, or do you need me to read that for you?
Well,
I can answer the question.
Oh, actually, so I'm going to reorient everybody, and I apologize for this because I'm going to have to stick to the questions for the executive team report can be responded to right now, but otherwise we have to go item by item. So the vacancy report, Mr. Pickens, would be the next item. So no, that's no problem, and I'll help you all stay in the right lane. But any questions that relate to or could be answered underneath the team report, the executive team report, is where we're at right now.
Okay, so looks like So there was one question related to, given the overwhelming work and change required, how are we using equipment, automation, and upgrades to address issues? And I believe Michelle Fouts from pharmacy is going to provide a response.
I don't see Dr. Fouts on the line today.
Okay. Well, I'll pinch hit. We, as you know, we utilize automated dispensing devices in pharmacy, Pyxis machines. So pharmacy is working along with our Chief Information Officer, Eric Raffin, to really look at how can we optimize both the Pyxis machines and particularly their interface with Epic, our EHR, so that we are better able to fill some of the gaps that have been identified related to regulatory compliance and how staff are working. So I hope that provides a response to that question. There was another question related to the inevitable staff and leadership turnover, and this was referenced in terms of just the increased amount of work that all the staff are doing, and as a result, and all of the required policy and procedure changes that we're making, how are those being codified and taught without overwhelming, particularly our new staff? So I'll let Naz provide a response to that.
Thank you, Roland. And good afternoon, commissioners. Happy New Year to you all. And thank you for the questions that you shared with us today. In response to this question of how we codify our policies and support our staff, all of our trainings that we provide to our staff through our Department of Education and Training are to reflect current policy. So meaning any time that a policy is updated, the trainings are then also updated for staff. We also communicate monthly, the same cadence as we review and revise policies to our staff of any revisions and updates, and also expect department managers and supervisors to review any changes with staff. There was another element that also, touched on, our staff expected to know all of the policies, or is it only those that are pertinent to their job or department? And it's both. So all hospital-wide policies. They are hospital-wide because the intent is that everybody should be aware of them, as it impacts more than one department. There are also departmental policies. Departmental policies are specific for that team. So let's say the Department of Facility Services, they have a slew of policies specific for that staff, which the quality management team, in theory, would not be responsible for knowing those policies because it's not to our workflow. So those are the two follow-ups for those questions.
Thank you, Naz. Another question posed was that the action plan for the RCA has included attainable goals and changes. How will these goals and changes be prioritized, i.e. what to accomplish first and have more time to show continued success? I think we've got Baljeet, Naz, and Terry on deck to provide a response.
I don't see Baljeet on the participant list, so maybe Naz or Terry can address that question.
Yeah, and I can start. I can.
Oh, okay, I was going to start.
I'll start. You can fill in, Terry. The action plan, yes, has a very numerous milestones and goals and requisite changes that go along with that. They have been prioritized by month. So the milestones are broken out to what has to be accomplished within each month: January, February, March, April, and completed by that May 13th deadline as required by the settlement agreement. So to the extent possible, we looked at the hundreds of milestones that were there, worked collaboratively through multidisciplinary teams to figure out, given the bandwidth that we have within the organization, where do we get the biggest bang for our buck in terms of which items can and should be addressed first and have the greatest impact on resident care, and try to tackle those first. The ones that were lower hanging fruit, we tried to tackle those first, and really leaving the ones that require much more interaction, thought, planning before we're actually able to achieve those. Those then have the later dates for completion in March, April, and May. I don't know if you want to add anything, Terry.
No, I think you have it. We are moving along with all our plan of corrections and using the milestones to help guide us. So thank you, Roland.
Great. So another question was, oh no, that's related to the PIPS report. We'll have to wait on that one. Oh yeah, so there was a question related to, can the team explain the relationship between care plans, CAAs, and PASSRs?
I can do that. So a CAA is done when by our utilization management folks, when someone is admitted.
I'm sorry,
or
Terry,
readmitted.
can you relate, can you explain what a CAA stands for? Just
I certainly can. Let me, I have my acronyms written all over the place. So the MDS assessment of a patient drives the care area assessments, which is the CAA, which is done quarterly. And PASSRs, which I will apologize, now I'll get you what that acronym is for, are completed on admission and readmission, as well as annual and any changes of the resident condition. This is completed by we did have a deficiency noted on our survey in 322. We have fixed that, and we are in full compliance. The PASSR is pre-admission screening and resident review. So that's what that acronym is. And they're related only, so a PASSR is initiated when a CAA demonstrates a new change of condition of a psychiatric illness or grave disability. If that goes to a level 2 PASSR, the PASSR, which is done quarterly, will then go to the state. And if they have an active psychiatric needs or grave disability, and there are 2, the PASSR score of level 2 goes to the state, which triggers a level 2 designation, and a psychiatrist from the Department of Health Services or the state reviews the patient's medical record, and they recommend treatments for the care plan of the resident.
Thank you, Terry. And we've got another somewhat related question. So as of November, only 13.5% of resident active care plans were reviewed. What is the current status?
Okay, that is true. That's 13.5%. We have totally about 150 now, which is about 25%. It takes up to 4 hours for each care plan to go through it and update it. And we are looking to have it completed by March of 2023. That being said, that does not mean we're not working on care plans. We're doing a revamp of 100% of our care plans. And in order to do them well, we're methodically going through everything, reviewing them, updating them. And then we're having help from our consultants to tell us if we have deficiencies and where we can work on those deficiencies as well. The majority of the findings that we are working on are related to wound care, trach care, and nutrition, and scattered of other minor issues. For wound care, during our survey, it was noted that we had a lot of deficiency. And at that point, I did a stop the line moment for nursing, and we required 100% of the residents, at the time there was 563, to have a complete wound skin assessment and a Braden score. A Braden score indicates if someone is at risk for developing pressure ulcers. That was done, and it was validated, and within 24 hours, we had 100% compliance. Based on that, we found that we had some wound care issues that needed to be followed up. We have deployed 3 people from DPH who have started their engagement with us and are looking at every single wound that was in that survey that we did, and making recommendations to the physicians and training nurses one by one. Trach care, we've worked on our trach care. We've worked with our respiratory colleagues and our clinical nurse specialist group to ensure that we are doing all of the bundles that you need to do for trach care. And nutrition, as part of the bundle, when we did the wound care and the Braden, we did weights and heights so that we can also work with our dietary partners, the dietitians, to ensure that diets and wounds are being treated together.
Thank you, Terry.
Mr. Pickens, can we move on to I think some of those could be maybe dotted throughout the other part of the meeting, but can we get to, I think we need to get to some public comment and then go to the commissioner comments, if that's okay?
Sure, let's go ahead.
Okay, great. Members of the public, we are, just to remind you, we're on item 4, the executive team report. So please make your comments about the executive team report. Each of you will have 3 minutes. I see 3 hands right now. Oh, sorry, I see 2 hands. All right, caller, you're unmuted. Please let us know that you're there.
I am. It's Patrick Lynette Shaw.
Okay, you've got 3 minutes.
It's ironic this report finally acknowledges the point I've raised extensively, that over time, Laguna Honda was being operated more like an acute care hospital. As I testified to the Commission's January 3rd Finance and Planning Committee meeting, Roland Pickens had admitted to the Health Commission last August Laguna Honda had been following the wrong regulatory guidelines. It's gratifying to learn the root cause analysis presented to CMS admits the main reason for causing Laguna Honda's decertification was because Laguna Honda fell out of sync with other high-performing skilled nursing facilities. The question becomes, have all managers been held accountable for the mismanagement of LHH? Hiring a licensed nursing home administrator would help. You should do that now. It's disturbing. Mr. Pickens is saying that you had a really short deadline to work on revising the policy and procedures quickly, and the timing had not been in your favor. That's ridiculous. The Phase 3 guidelines went into effect 3 years ago in November of 2019, and the only thing new is that state regulator guidance has finally been issued so that the state surveyors can issue deficiencies if the Phase 3 guidelines have not been implemented. You guys should have been working for years on revising those policy and procedures. It's disturbing hearing that the request to CDCH about extending the pause on discharges is still under review by the city attorney. That should have been accomplished weeks and weeks and weeks ago. And the public needs more information on how that immediate jeopardy citation regarding the fire violation discovered during the monitoring survey has been solved, and whether CMS accepted a fine, or whether CMS found that that violation had been completely cured and that you're back in back in compliance.
Thank you. All right. Oh, I see two other hands. Hi, you're unmuted. Please let us know that you're there.
Yeah, this is Michael Lyon from Gray Panthers again. I was very interested to see that one of the 8 areas of concern for the root cause analysis had to do, well, one of them had to do with residents' rights, and another had to do toward moving toward skilled nursing excellence. The needs for people with psychiatric issues and with substance abuse issues, those patients need very, very close kind of supervision, and which is completely out of, in completely contrary to the residents' rights in for a nursing home and a skilled nursing facility. So, and in addition, moving toward excellence in nursing home positions means that the nursing home itself must have the ability to regulate who gets admitted into the hospital. So both of those things say that the flow project or anything approaching the flow project cannot happen, or if it does happen, the concern for the root cause analysis really means nothing. I agree with Patrick Manette-Shaw that this is long, long overdue to be working with the city attorneys to demand a pause and extension. My God, we're talking about less than a month from now for a policy that, for a contingency that killed 20% of the victims of it. I also think it's stretching things, to put it mildly, to say that the rights of residents in the transfer process was anything. Residents weren't informed of their rights. One of one of the residents who was able to challenge his rights and tried to come back into the hospital was arrested for doing this. So no, there was no patient's rights that were involved in the transfer. The other thing I object to is Mr. Pickens saying that those who were transferred out went to good places, is what he's trying to imply. But we know that that's not true, that some of them were sent to homeless shelters, and those that did go to...
is up. Thank you very much. I'm always sorry to cut people off, but everyone has the exact amount of time. I see one other hand. All right, caller, you're unmuted. Please let us know that you're there.
Oh, hi, this is Dr. Teresa Palmer. And as a doctor who spent many years at nursing homes, I find the situation with the policies and procedures and with the inspections extremely discouraging. The things that need to be done are things that should have been routinely done on a regular basis for many years. The recitation about wound care is the most basic policy about taking care of wounds that any nursing home should have. It doesn't have to be a high-functioning nursing home. Any nursing home should have. Not having a Braden score and a height and weight and doing a full skin inspection is, it's like the Bible. I mean, why would this not be being done at Laguna Honda? And so I'm really hoping that there's a way to extend the discharges, because we know people will die if they have to go to these for-profit chain institutions outside of the county. And the only thing I can think of is to throw yourself on the mercy of the state and the feds and every elected representative you can think of, because it's bad for the patients and it's bad for the people to resume discharges. And just keep at it and try to make sure that this profound neglect that Laguna Honda has suffered in since the Flow project has been in place will not be repeated. Please. Thank you.
Thank you for your comment. And commissioners, that is the last hand I see.
Okay, thank you. Thank you all for your commentary. And thanks again, Roland and team, for the report. Now I'm going to open it up to questions from members of the committee. Let's see. Dr. Chow.
Yes, thank you, Mr. Pickens, for a very substantive report. And I believe you can confirm that it's my understanding from the periodic survey when we had the immediate jeopardy that has been fully resolved. And I think that'd be a comment I'll ask you to make in a moment, just to confirm that. What I saw and am really pleased about was that the RCA does speak to some very important chapters or topics, I guess, that we could say, and that it sounds like the milestones that we're looking at fall into these categories. So as we develop a new action plan, I'm hoping that we'd be able to see that these categories probably do have some order of priority, because we had them before in terms of which were potential K resolutions and others B, as you say. And so while we're looking for the low-hanging fruit to immediately resolve, I would hope that the remainder then are prioritized in some sort of way related to the severity or the importance, I should say, for quality of care, which, if I remember, is how that rating was. So that was one thing I was thinking about as I was listening to your presentation. Another was that trying to read my own writing here now. Oh yes. On the closure plan, I understand that you are continuing to work on that, and that is good. So I'm hoping that as soon as we understand and possibly an update at our next commission meeting, which is only a week from now, that'd be, I'm sure, hoping that we will get some good news, and I'm hoping the residents will hear about it even sooner than we do. But I understand the intensity of the work that's already going on and has been trying to get that answer, and that it seems that CMS has chosen not to give an answer, and that you've now also then, or have continued to work with the city attorney, since this is um, uh, a settlement to do. Lastly, in regards to Laguna's recertification, I'm pleased that lessons learned out of the transfer are more administrative and process oriented. It's a shame that CMS didn't have that type of criteria before when you were talking to them about what would be an acceptable transfer plan. But you know, everybody has a little piece of action in here, and it seems to me also the nursing homes who thought they could handle certain cases might be looking at what their own admission criteria might be and their own challenges. Um, so that was, I think, what I wanted to comment on in regards to Laguna, and then I had one more comment. But why don't we just see if you have any responses in regards to our recertification efforts that you've been talking about right now?
Yes, thank you, Commissioner Chow, for your questions. And so, yes, very similar to how we handled the mock survey and prioritize those actions based on the severity index that CMS uses. We will be doing the same thing with the action plan for the RCA. So we will be monitoring that and sharing those results with everyone, just as we did for the mock survey. So you'll see a similar kind of report based upon severity and how we're tackling and taking those off the list as they're completed. And your other question, comment was about, the immediate jeopardy for fire life safety. Yes, that was resolved while the surveyors were here. So we were able to clear up and satisfy that we were complying with all the applicable fire life safety requirements that led and fix those deficits that led to the immediate jeopardy.
Thank you. I had one other question about the COVID report. On the staff report, I noted and certainly noted most recently that, and it is good that you are listing how many of the vaccines everybody has had who have been positive. But it seemed to me that some of the people are saying that they only had like 3 boosters, and I'm wondering, because of the efficacy of the bivalent booster, if there has been a strong effort to see that staff actually not only has access to it, but really are encouraged to get it, because we're still seeing a large number. I consider that a large number of staff. Uh, Considering that they're supposed to all have been vaccinated, and that seems to be a very high percentage. But do we have an idea of the percent of the bivalent booster? And if not, or if it's too low, whether we have a more active campaign? Because I think that would be our most effective vaccine strategy right now.
Thank you for that question, Dr. Chow. I'll ask our hospital incident commander for COVID, Dr. Lisa Hu, to address that question.
Thank you. Thanks, Roland, and thank you, Dr. Chow, Commissioner Chow. So yes, the bivalent booster is lagging behind, I believe. We're very proud of our resident rate, which is 89% bivalent vaccination, and that's wonderful. Our staff vaccination rate for bivalent is lower. It is in the mid 40s percentile. And there's a couple of reasons. First of all, you'll notice that people have had about 3 vaccinations. That was mandatory, the initial, the primary series plus 1 booster. And since then, there has been another booster available to those over 50, and then the bivalent. And I think that it is a personal decision sometimes for people to take it or not take it. And generally, when it's not mandatory, to be very honest, that sometimes people may be a little bit lax. We have had a very robust campaign here to try to increase those numbers. And we have had a mobile vaccination cart go. It's a concierge service to go to people's place of work, the units, their offices, and offer the vaccine right there on the spot. We have, our clinic has been very generous with many hours open Monday through Friday for just drop in for vaccination. And we have actually held raffles and prizes, and we have provided small snacks and treats for people who come in for any vaccination, the flu or a COVID bivalent booster. While our rates aren't where we want them to be sure, and we want to catch up with our residents who have done such a wonderful job and accepting the bivalent booster and getting themselves vaccinated with it, and we are higher than the community. For whatever reason, we've noticed that the community vaccination rates for the bivalent are a little bit less than what would be desired as well. So we continue on with that, with our campaign with that, and trying to think up novel ideas of encouraging people and making it fun for them, such as the raffle and coming by for a snack or something in the clinic.
Well, I would just wonder that if we, put it not only upon them as a personal choice or personal health issue, but to indicate that, while we can't prove it, that a that our residents are really very vulnerable, and make that sort of another responsibility. If we're not making this a mandate, it just seems that we're it's coincident, right, that the larger number of staff that seem to be positive, then we are getting residents again infected. And I think that perhaps that could also be another emphasis if it isn't happening now. So thank you very much. I don't have any other questions at this time.
Thank you. Yeah, I forgot to mention that we do emphasize in the line of work we're in to protect our residents and to protect each other, that it's extremely important.
Okay, thank you.
But prizes speak words too, so thank you.
Yeah.
Thanks. Thank you.
Thank you, Dr. Hu, and thank you, Commissioner Chow, for your questions. I'll turn now to Commissioner Green.
Yes, well, thank you again for this really extensive and informative report. I want to make sure I fully understand, because, looking at the volume of policies that you've produced, am I right in assuming that what we really have is the scaffolding we need for virtually everything we're facing, for an RCA, for the phase 3 policies, for anything that might come up in 2567s, that basically the guidelines and the rules and the methodologies for approaching any of these things have basically been codified in the documents that we're going to talk about shortly. And then, I was also kind of struck by the idea, and I'm curious to know if that's correct. And also, I was kind of struck by the fact that as I looked over, especially the transfer report and some of these other items, 2 things. First of all, I think we are all very concerned about the stress on the staff, not only from the perspective of the way they were have been interviewed routinely by surveyors and kind of caught off guard, which has got to be unbelievably stressful, but also some of the aspects of staffing. And we know in San Francisco, we have massive issues with staffing in virtually every institution, outpatient and inpatient alike. And I hope we can support you in any way we can, both to keep the morale afloat, but also to try to figure out innovative ways, including outsourcing, for accomplishing some of the things we need. But what struck me was documentation has a lot to do with it, and that there is somewhat of a disconnect between what's actually done at Laguna, as evidenced by how excellent our results have been with COVID, for example, and what has been put on paper. And I know we're brand new to EPIC. I mean, most institutions have been on it for a decade or more. We've been on it since August of 2021. So that gets to this, I guess the three things I'm thinking about. One is to corroborate that in fact we have the scaffolding we need to move forward for any eventuality. Second, that we're trying to figure out creative ways to both automate or otherwise use EPIC optimally to minimize staff work, and of course with that increasing morale. And I think how we bring that all together, I'm really interested in learning more about. And I was also very happy to hear in public comment that the unions are working so well and so collaboratively with everyone at Laguna. We all want to keep this institution open. All of us across the board are in agreement. And I'm curious just for a little feedback on those aspects, the workforce, the documentation, and whether you feel confident that what we have is really anything we might need to turn to. And a correlate to that, are any of the documents available on the intranet? Because one of the things that concerns me is there's such a body of information, I can't absorb it all. And so how do staff members, like all the definitions in there, for example, is there a simple, quick place they can refer to get that information? So those were some of the I know that's a lot, but those are some of the concerns or questions I had.
Sure. I can start and then ask, I think probably Jen, Naz, and Terry to kind of fill in any gaps that I may have. So in terms of the question about do we have the scaffolding? So in terms of all of those pages and pages of policies that you receive, to the best of our knowledge, as of today, that is our best attempt at making sure we have the scaffolding in terms of policies that meet all of the CMS requirements, including phase 3. And also, because remember, we also still have the acute care hospital license that also meet the Title 22 regulatory requirements. So, we've consulted with our consultants on our policy and procedure changes. And so everybody has signed off. To the best of our knowledge, as of today, we've gotten everything covered in these policy and procedure revisions that have been forwarded to you. In terms of documentation, you're absolutely right. I think the last 8 months, and particularly the RCA, really shone the light on the challenges that we've had with documentation, particularly as it relates to capturing that documentation within our EHR, which is EPIC. Luckily, we, and Terry can talk more about this, but we've gotten Eric Raffin he's on the job, he's on site. He is leading, he personally, as the DPH CIO, is leading the effort to get to the bottom of how do we optimize, number one, can we, and so far the answers are yes, can we optimize EPIC to have it provide the functionality that high-performing skilled nursing facilities require, particularly when it comes to capturing documentation for care. Eric is leading that multidisciplinary group, and we are confident, and we've been assured they will work with EPIC to make whatever the necessary programming, optimization changes that are required for us in order for us to meet the needs of our skilled nursing facility residents. And so that is an ongoing process. We will make sure that we keep you and everyone else informed as to how that's going, because we know that will go a long way in both improving care, but also improving the quality of life for our staff, so that it's an easier job for them to do the right thing when it comes to documentation. There was one other. Oh, Terry, did you want to talk about the EPIC? And Claire Horton is also on the line, but Claire has laryngitis, so she can't talk, but she has also been working particularly on the EPIC optimization with Eric and Terry. But Terry, I don't know if you want to talk more about that.
Sure. One of the greatest things that we're working on now to optimize Epic is a nursing Cardex. The Cardex is a plan of care. So our staff are using Epic really well. They're using their work list, but this is something where you can give a detailed report about each resident from staff member to staff member. And so a meeting was stood up on Friday by Eric Raffin. It's attended by both ZSFG because of 4A and Laguna, so that we can have the same Cardex up. So that's the first part of optimization, which we're very excited because that will really help in utilizing Epic better for the nursing home.
Great. And then any comments just about creative workforce issues? And it's as I said earlier, you know, it's just as you look at all of this, there's so much we're doing things, and it's just the way it's put on paper that isn't being recognized for what we do. So I'm delighted to hear about the Epic optimization. And what about just all the some of the workforce issues, both from the stress perspective, but also from the adequate manpower perspective? I know that covers huge different numbers of different divisions, but you know, there could be a lot of need in a resource constrained environment, especially with nursing.
Mm-hmm. So I think Terry can address the workforce component, and I'll ask Jen Carton-Wade to address the quality of life care experience component of your question.
Great, thank you, Roland. So in terms of nursing, I've been looking at who do we hire, who do we recruit, how are we onboarding people? And what I learned was we didn't really have a robust new grad program. And there are a lot of new graduates from Dominican, USF, CSM, Samuel Merritt, USF. And I've been meeting with the deans and the student placement coordinators, and I've been working with DHR. And yesterday, we added a training program link for Laguna Honda, and I'm happy to say that 3 people have already signed up for that link. So we're looking at being creative in our workforce. We're developing a training program. I'm going to work really closely with my colleagues at ZSFG, and if we have to instead of duplicating classes, how can we best work with each other to optimize training and bandwidth? For bandwidth and things with wound care, we've deployed 2 from ZSFG, 1 from Health at Home. They're doing their work there and they're coming over and supporting us. So I think that it is a lot of work. I'm not going to deny that there's not a lot of work that people are doing, but all of that work we're doing enhances our patient resident care, and it's work we need to be doing anywhere. And we're just looking at workflows to how to better serve our residents.
Thank you.
You're welcome.
Jen, do you want to go ahead and respond with your part?
Sure. Yeah, it'll be relatively quick. Nice to see everybody. What we're doing right now is hard. Full stop. It's hard. We're all in a moment of change management and learning how to move big things forward with not a lot of time. And I would say, as we approach all of the work, we're working closely. Ami Fishman, who's the director of equity and culture, we're working closely together with like DHR and making sure that we can help approach some of these changes in a way that's staff feel supported by leadership, by each other, really, and that they can all recognize that we are really going through this together. It's not, you know, one of the things that I'm really focusing on is more of a community approach, because we are all going through it. Like, you know, we've all now have exposure to the action plan. We understand what that means from the top, you know, the executive leadership to frontline staff, and knowing that frontline staff are doing the hard work. We're all doing hard work, and it's all building things so that we can, you know, really support Laguna Honda to move forward into the next steps. And so honestly, creating a culture that's more of a brave culture to name things when they don't feel good, to say things when things need to be said, and to be felt like you're being heard and included. And so a lot of our leadership branding that will be coming up like very, very shortly will help to address some of those things. So that's just a very top level overview, but absolutely knowing and feeling the pulse right now. And we're all like, for me, I'm a big hippie anyway, but we're all in this together and we all need to support each other. The only way through is going to be through all the hard stuff, and we can only do that together. So that's the sort of culture that I would like to help support as we move forward.
Thank you so much, because you're basically empowering, emboldening, and encouraging and creating community, which is so important to retention as well as recruitment. So very, very much appreciate your efforts and everything that the whole team has done. Very, very encouraged by what we've heard today. Thanks so much for your forbearance in these questions.
Thank you. And thank you for your questions. I will follow up with just one general question and maybe a comment, but sort of following on Jen's sort of positive, looking forward statement about, how, what kind of community and culture you're trying to put in place. Then positively, I'm going to assume that CMS is going to be able to approve the action plan and will not insist on additional transfers or discharges. And if that is the case, or even if they're just sort of minor adjustments, just to clarify, the bulk of the work is already in place to move towards the implementation of the action plan. We are not waiting for CMS's approval, right? I mean, all of the dashboards that we're getting and all of the reports that we're getting from you really indicate that there is, and everything that you've all have said, have indicated that this body of work, not to mention what we're going to be discussing later in terms of the revisions of the new policies and procedures, this body of work is not waiting on CDPH or CMS to say go. We are in place, and to the extent that there might be any changes or adjustments and such, we will be able, as in response to Commissioner Green's question, their scaffolding is in place in order to be able to continue forward as opposed to moving backwards. And particularly if the May deadline is going to be critical in terms of an indication of sort of positive and appropriate execution on the action plan. We all need to just be sort of orienting ourselves in that sort of positive manner, even with all of the things that are still sort of unknown up to that point. So I just wanted to be really clear. The work is being done. The bulk of the work has been in place. We have the strategies in place. We have the operational structure and framework in place. The execution discipline has been, in formation and will continue. And then the quality, safety, and performance monitoring, any adjustments that have to be done related to that, is an ongoing indication of the excellence that we're trying to now put in place as Laguna Honda sees itself reorienting and reestablishing itself as the skilled nursing facility that we all want to see continue for the future. Is that a good statement of where we're at?
Absolutely, and thank you so much for highlighting that. Yes, the work is not waiting. In fact, has been happening ever since the hour after decertification on April 22nd, and it's like a snowball. Every month it's gotten bigger and bigger. And thank you for pointing that out. For those of us who are here in the trenches, we tend to just put our heads down and just push through doing all these things. And so we don't always, I think, do a good enough job of really laying out just how much effort is being expended by everyone at Laguna. But yes, luckily that the RCA it was helpful in identifying those 8 categories. But those categories, again, were not surprising. They were things that had been identified over the last several months through the initial consultation. And just the RCA allowed a process to go back over several years rather than just looking at the current point in time, trying to be more holistic. And so it really has validated a lot of the work that we've done since April of last year. So yes, the work we, just as we did in mock survey 1, you'll recall we had 101 FTAGs and a little over 200 milestones. This action plan is the same way. I think we're going to end up with a little over 300 milestones. So, and we didn't wait to start. Some of those milestones, have been in process for the last several weeks, and will be concluding in the days and weeks to come. But yes, we haven't held back. We're going 150 miles an hour, full steam ahead.
Okay, great. Glad to hear that. And I don't see any additional hands up from members of the committee or anybody else at this point. And so I think, Mark, we can continue on with the agenda.
Sure. I am going to, for members of the public, I'm going to lower hands because we're moving on to a new item, just to make sure we're all clear. And the next item is item 5, the hiring and vacancy report.
Thank you. Good afternoon and happy New Year to all. This is Carrie Johnson, HR Manager at Laguna. For a brief summary for Laguna hiring and vacancies, the data run for end of last month, we are at 11.1 vacancy rate overall. We had 12 employees start in December and we had 2 separations. Some of the challenges are noted on the summary, including few candidates on the nurse, long-term care, and the patient care assistant eligible list. We're partnering with Merit to provide regular and frequent refreshes of those lists in order to capture any new applicants. The hiring managers are also doing application review on many recruitments in order to speed up those selection processes. Terry just mentioned it. Nursing has decided to move many of those experienced RN vacancies that you see on the report. There were 23.5 of them on this last month's report, and change those to new grad positions. We call those training positions. We know that training positions are very popular. We should have no trouble filling our vacancies with training applicants. And so we look forward to that. Our Merit team is expecting that list in just a few weeks. So we hope to have that shortly to start moving on some of those new training positions. And just as an update where we're at right now, we're onboarding 7 permanent nurses, 1 P103 and 8 patient care assistants targeted with January and February start work dates to assist with direct care to residents. And in addition, I highlighted that 2 nurse managers just started. We'll start to work dates of January 7th. The next new employee orientation is January 23rd. Right now we have 16 tentative new employees starting on that day. And now I open it up to additional questions.
Okay, let's see if we have any public comment on this item first, Mark.
Sure. Folks on the line, we are on item 5, the hiring and vacancy report. Please press *3 if you'd like to make public comment about this item. Any comments would be about the hiring vacancy report. I see 1 hand. All right, you were unmuted. Please let us know that you're there.
Hi, this is Dr. Teresa Palmer. Can you hear me?
Yes, please go ahead.
Hi, yeah. My question is, if you're replacing an experienced RN with a new grad, isn't that problematic in terms of the quality of nursing care? Thank you.
Thank you very much for your comment. A public comment, commissioners.
Okay, are there any questions the commissioners. I do want to, I remember that there was an item on this item, or a question on this item, that Roland was going to answer as part of the executive director report, but you pushed him off to now. So unless there's an additional questions, I think if Roland can reiterate that question and answer, that would be helpful.
I think it was my question, and maybe I can rephrase it given because it went in before the report. So I guess there's two things that I'm curious about. The first is, and I don't know if this would be a heavy lift, so absolutely shoot me down, but it would be very helpful for us to get a sense when, like, there are 22 nursing vacancies, what that means in terms of percentages of the overall staff. So I guess I'd be curious to understand, and we don't need the numbers, but if there are anywhere, you've got some benchmarks for when the water, well, in this case, what's going on, the water level gets so high, we're going to say low, that red flag is raised. Because as I looked at some of the information we had, there were elements that it could have been completed more rapidly. Everything from central processing to getting people back on pass and care plans and things you've already mentioned that have as a rate limiting factor some staffing. And it's not just nursing, it's pharmacy, it's the environmental staff, it's that whole grouping. So I'm wondering if you are kind of following the watermark for when there isn't some kind of alarm or concern, and how you would share that with us. And the other thing I'm wondering is, you talk about the new grad programs, and that's great. And they are so easy to fill. But do you have internal programs to replace nurse managers if they retire or step away? In other words, you probably have identified staff, especially on the nursing side, that look like they have great potential. And I'm wondering if there's an organized approach to, which was the second question, an organized approach to growing from within, especially because if some of the higher level frontline staff, leadership and frontline staff we lose them for any reason, including even a leave of absence, it really does set us back, since their responsibilities are so significant. Wondering if what you're doing to train understudies or people that might fill those shoes in the future.
Those are great questions, and I can answer them. For the latter part of your question, you're right. Nurse managers retire, they move on, they get promoted, and they go other places. And what I had to do was, I'm standing up charge nurses. We sent out a query to all our charge nurse group who would like to do interim manager. We train them, and currently we have 2 charge nurses that are doing interim manager. One of the charge nurses, we have a new manager for that unit. I'm not going to put her back in charge. We're going to have her cover for other managers and to help with managerial duties. This is building our bench. It's developing our people so that when we do have an opening ready, we have people that can go on the list that have worked long-term care and are trained up and understand what the job entails. So that is something I'm very proud of, that we are really working with our charge nurse group to develop their potential. And if they want to do a clinical route, whether it be a clinical nurse specialist or the leadership route into manager. So we have 2 right now, Kathleen Lazan and Carla Calderon, who are doing amazing jobs. In terms of staffing, our census is a bit lower, so that helps with numbers. And the second part is not all the RNs that we have, we are looking at the functions of the nurses. And in the past, or in the recent past, all of charge nurses and managers were doing care plans. We are now transitioning that MDS will own the care plans, and updates will be made by charge nurses, licensed nurses. We are looking at what is ownership that the nurse at the bedside can do. So we're really optimizing the bedside nurse to do bedside nursing care. The question you asked about the training program, we have really talented long-term care people. We have a group of CNSs. We have a group of educators, our charge nurses. The longevity here at Laguna Honda is great. And there are people here that have a lot of knowledge. What we need to do, and what when I spoke to our Director of Education and Training, Crystal Figlietti, they have a program that they already put together, but they were never able to sort of implement it. So I'm taking it to the next step. We're implementing it. We're going to have consistent preceptors. There are certain things that you have to have in place in order to be successful. And so we're putting those elements in place so that we can get people that are successful. And then if they've been at Laguna for 2 years and they love it, they can move up. Their DPH is broad, they can go to other places. But we're really trying to look at how we onboard our staff to ensure that they're successful. And by putting a training program together that really looks at continuity, training classes, and whatnot, I think we can achieve that. And in terms, I don't know if I said this, the staffing, I did say that we do review staffing at the minimum 3 times a day before 2 hours before shift. We take right after shift if people don't show up for whatever reason. The nursing directors and managers are on it. They look at it. Where do we have to move one to another so that we can make people whole? So we are really very agile to and looking in our nursing ops department to make sure that we have optimal staffing.
That is great. Thank you so much.
And then to answer your question, 22 people out of the, that represented, I believe, 11%. The good news is, I just had a report from one of my managers. We just hired 6 nurses. So that number is going down. They're going to be onboarded in the next, we put offers in. They now have to go through the HR process. In terms of that, the other thing that we struggle with too is that we do have people on leaves and we have daily sick calls. So it just is it's not one number, it's a collection of numbers. But the good news is we do have agency traveler nurses that come in to support us as well. And currently we have 23 that are on board to help with our issues.
Well, thank you. And I would never underrate the difficulty in nursing staffing. We live it, and it's dire. In my own institution, really dire to the point that we can't admit inductions. We have a lot of challenges with nursing. So the fact you're doing better than a lot of acute care hospitals, quite honestly, especially in your hiring. So thank you.
Okay.
Thank you.
I see Commissioner Chow's hand up.
Yes, thank you. And I was wondering, one thing that I think Commissioner Green was noting was trying to understand, I think, what 23 meant, not just simply whether it was 11% or is that a critical number? Because the percentages we do get. And I think that Terry's given us a new nuance that it isn't just the non-hired vacancy, but the number of people who are out. And I'm thinking that we have been trying to understand, I think your narrative does try to indicate whether or not, these are significant numbers or not. So I don't know exactly how to do it, but I thought that's a nuance that might be of some interest to try to figure out. Probably in the narrative, we've also had so many, so this is a high priority or not, because I think that was where we were trying to decide. So understanding that nurses are of high priority, my one question, as an aside, by the way, there was a DPH, California DPH and CMA seminar today describing Kaiser Northern California's approach to COVID. And of course, they have just like 20 some odd hospitals and all. And it's very interesting that as he listed the challenges in terms of steps to try to address COVID and education of COVID for his millions in Kaiser, that number one item is staffing in order to carry out any of these wonderful, segments of plans that they have. So I think it is a challenge, and I would agree with Commissioner Green. It looks to me, as we've compared to that we still, while having a challenge, are doing very nicely, as much in the city as perhaps anybody else. But as I was reading this, and this is what I had circled over the weekend, I wasn't sure that if these were important, and maybe this is just a matter of definition, uh, thinking that we needed to hire these nurses, it then says in your explanation, pending announcement. So I'm not sure, pending announcement doesn't sound to me like it seems to be the most urgent. So am I wrong on what pending announcement means? Because I would think we've gone beyond the announcement phase and we're trying to search for them.
So I can help with that. Thank you, Commissioner Chow, for those comments. Nursing is a priority. We're Department of Public Health, so RNs everywhere are always going to be a priority for us. You're right, we're doing probably better than most institutions, but we do make it a focus. We know this is a challenging market, so we must move forward and take proactive measures to try to get nurses on board. Just to explain how the nursing works, it's what we call a continuous posting, so it refreshes. So we'll have a posting up, it gets adopted through the civil service process, and then we look for candidates on that current list. Then we have to wait another 2 weeks, 3 weeks for a new list to be adopted from the merit team. So while we might have a list, our nurse managers contacted everybody and made offers to interested qualified candidates, but there weren't enough candidates. And so now we're just waiting for more candidates to apply and a new list is being adopted. So it's going to be on a continuous basis. Roughly, Merit is working on a 3 to 4 week time frame for this specialty so that we can get new candidates on a frequent basis so that we can fill these positions. And so we do have to post. Training is not what we call a continuous posting because we don't want to have people apply and then we wouldn't have a training class. Normally those are done like quarterly at Zuckerberg, right? 3 or 4 times a year for some of those specialties. So we want to make sure we were to have a fresh posting with applicants apply. So yes, Merit did need to post for this training, this new training. That we are moving on, and we should have that list in a few weeks because we can no longer do those direct hires. I know that I've mentioned that in some other calls. That would have been much faster, but now we have to wait for an adopted list to go through that civil service process, and then we can provide those candidates to these managers to make a selection. I hope that answered the question.
In addition to what Carrie's saying, there's a work group working with DHR under the leadership of Luana Kim to streamline and move this faster. So we understand the competitive market. We are working together. That's how I was able to get Laguna Honda a training designation overnight so that we are moving quickly and we are responding to the times. And it's been a great collaboration between HR and the hiring teams.
Okay, so I think you explained that pending announcement doesn't mean that you're just waiting. But then I would wonder, and maybe Terry can answer this, if we held more training, educational programs rather than every quarter, wouldn't we be able then to try to attract more people during that period of time? Or does that?
So, no, it's very nuanced. So if you're talking about general, they have specialties. And to be an ER nurse, it takes 3 months for a new grad. For ICU, it takes 4 months. For OR, it takes 6 months. For labor and delivery, it's another 4 months. But for Laguna Honda, I have committed to take up to 10 new grads per month.
Oh.
And so where your limiting factor is preceptors. So if you have people out, your most senior people out, you want to give them the best experience. So you have to balance training with the staff you have. And at general, I can speak from experience because I know that there was a time that people were getting tired because every 2 months they were training people and they weren't able to practice independently. And so COVID has taken a lot of that away, but we are resilient and we are going to come back from that. And we are going to absolutely train people. And within DPH, there's also reassignment. And so someone has the right to reassign to another area and for a training program. So there's a lot of nuances. And so what I'm trying to make Laguna Honda is a springboard, such as MedSurg at San Francisco General. So if we can get new nurses, train them, our patient, we'll do fabulously with them. We just have to invest the time and ensure we have proper training.
No, thank you. And I'm sorry that it's so complicated to get somebody trained, but appreciate really the nuances that you're giving us.
Thank you. Thank you. And just as a personal aside, as somebody whose daughter is going to be graduating from nursing school in a few months, it's really glad to hear the robustness of your intent on the training and the
Gina,
opportunities.
just for a plug for DPH, we are a really good training zone. People want to work and train at this, and the Sutters and the Stanfords with their big, massive raises, they don't do training programs. We give an intensive, really well-run training programs. So I look forward to working with your daughter one day, wherever she goes.
And I'm going to interrupt right now. And that would be a formal process, and she would be treated like everybody else. And blah, blah, blah.
Absolutely.
There's no.
Absolutely, but nursing is a community on its own.
Yeah, right.
Yes. Yes. Okay. Let's see. I don't see, Dr. Green and Dr. Chow, your hands are still up. So I don't know if you have additional questions or, okay. No? Okay, great. So I think then, Mark, we can move on to the next item.
Sure. And members of the public, I'm going to be putting down your hands now so that we can move on, and you can put them back up if you like. Item 6 is the finance update.
Hello, everyone. Good evening. I've got the finance update is the Q1 report, the gift fund report, and then the Q1 Laguna financial report. So I'll start with the gift fund report. Should be pretty quick and straightforward. So as of the end of Q1, we had $405 in donations and $35,000 in expenditures. We're at this point at the end of Q2, so we'll have the Q2 report soon, and we'll see some additional spending in Q2 for our holiday wish list and some of our other programming, including against our contracts. So kind of right where we expect to be on the gift fund for this at this point in the year. On the financial report, I think the DPH CFO has already presented the DPH financial report to you, but I can give a little more details. So for Laguna, we're currently projecting a $27 million deficit, primarily due to a almost $24 million shortfall, Medi-Cal shortfall, revenue shortfall, due to lower than budgeted census because of the pause on admissions. This model is currently based on us assuming that we're resuming admissions toward the end of Q4, but we're monitoring it closely and adjusting our forecasts as we get more information and as things change. It's also, the deficit is also due to $7.5 million overage in non-labor recertification expenses, namely our consulting expenses and some additional registry expenditures due to the recertification process. That's partly offset by salary and fringe savings due to delayed hiring. And then we're also kind of trying to reprioritize to cover additional recertification expenditures as they come up. And then there were a couple of questions that came through that are somewhat finance related, so I'll try to answer them. The first one's definitely finance related. It was, where did the consultant fees land on the DPH budget? Are they on the Laguna financial report or the DPH? So they are on both. So they are on here, as I just explained, with the overage and the non-labor expenses. And then that also rolls up to the DPH financial report. So that's where they are. And then there was a question about whether the action plan that we're putting into place is limited by budget constraints. And at the moment, it's really not. We're doing a lot of reprioritization to make sure that anything that comes up is addressed right away and prioritized over other projects and other expenditures that we may be able to put off. So that's kind of the puzzle that we're putting together right now to make sure that the things that need the most urgent attention are prioritized from a budget perspective. So, it's constantly changing and we're constantly adjusting to try to be responsive as requests come up, but that's, at the moment, we're not having any budget constraints to implement the action plan. And I'm happy to answer any other questions that you may have.
Okay, thank you, Lily. Let's see if there's any public comment on this item.
Sure, Commissioner. Folks on the line, we're on item 6, the finance update. If you'd like to make comment on this item, please press *3 now. I don't see any hands, so we'll give it a few seconds just to make sure. See a hand.
You don't see a hand?
I do see a hand now. I've just unmuted the caller. Caller, you've got 3 minutes. Let us know that you're there.
I am. It's Patrick Manetshaw.
Go ahead.
It's kind of disturbing hearing that new admissions may not resume until the fourth quarter, towards the end of June. The actual first quarter report had projected that admissions might resume at the end of the third quarter. The update presented the first quarter report for the period ending September 30th, documenting that $27 million deficit was caused by $24 million in lost Medi-Cal revenue due to the denial of payment for new admissions. Discussion of this report has been postponed twice at the full commission. It had been presented in December. It was supposed to have been discussed on January 3rd, and it's been delayed again. Where is the finance update for the second quarter that ended on December 31st? Have we had another additional $24 million in lost Medi-Cal revenue? How soon will that second quarter report be presented to the full commission and actually discussed during a full commission meeting? I think you should prioritize getting that second quarter financial report presented to the full health commission as quickly as possible. Thank you.
That's the only hand for this item, Commissioner.
Okay, are there any additional questions from members of the committee on this item? Finance update. I don't see any. Again, thank you, Lily. Let's move on to the next item.
Great. I'm going to put down the hands on the public. So we'll start a new item. Item 7 is the regulatory affairs report.
Good evening now, commissioners. So today I'm actually going to share with you 2 months worth of regulatory affairs activity that will reflect the months of November and December, as we did not have open session in the month of December. So you have these reports in front of you. For the month of November, Laguna Honda had a total of 16 facility reported incidences. We had no anonymous complaints. Of the 16, 14 were allegations of abuse, with 6 resident to resident, 5 staff to resident, and 1 other to resident, as well as a potential injury of unknown. For survey activity in the month of November, we started our CMS monitoring survey on November 28th, and this continued to December 16th. For plan of corrections, we actually submitted 3 plans of corrections for the month of November. These are facility reported incidences that were closed out by CDPH. As you know, they've been coming on site weekly, essentially, until we had our monitoring survey. And so these were deficiencies noted and acceptable plans of correction submitted to CDPH. We hosted 4 site visits in the month of November. Those were these weekly visits where they closed out several facility reported incidences during that month in an effort to clear their backlog. We still have 184 pending cases. I will move to the month of December, if that's okay, Mark, and then go for questions. So for the month of December, for the regulatory affairs report, Laguna Honda had 17 facility reported incidences, and we had 2 anonymous complaints shared with us by CDPH. Of the 17 incidences, or a total of 19 cases, I apologize, 15 were allegations of abuse, 9 resident to resident, 3 staff to resident, 1 other to resident, and 2 injury of unknown. We had actually, so we wrapped up our monitoring survey on December 16th, and then we did have a surveyor come join us on December 20th to follow up on a facility reported incident. And at the end of December, we still had 185 facility reported incidents pending. And then, of course, you have the breakdown of the outcome of our reports. The gray is becoming less and less over time, but still a lot to go. CDPH will likely continue their regular cadence site visits to close out these facility reported incidences, and then also share with us any complaints that might come their way. Happy to answer any questions related to the regulatory affairs reports.
Thank you, Naz. Let's see if there's any public comment on the report.
Yes, folks, we are on item 7, the regulatory affairs report, plus press *3 if you'd like to make a comment. I see 2 hands. Hi, caller, you are unmuted. Please let us know that you're there.
Hi, it's Doc Palmer again. It must be very confusing to have CDPH working on a backlog of stuff that goes to long ago at the same time that you're trying to get up to speed. And so it kind of, maybe that's one thing to point out to CMS, that since CDPH, I mean, I don't diplomatically, but since CDPH has kind of dropped the ball, it seems to me like Laguna Honda shouldn't have to pay for it. Thanks a lot.
Your comment, your observation. All right, next caller, you're unmuted. Please let us know that you're there.
I am. It's Patrick again.
All right, you've got 3 minutes.
The December report revealed CMS's contracted surveyor Healthcare Management Solutions arrived on November 28th, along with CDPH, to conduct that first 90-day monitoring survey. And that the initial exit date was supposed to have been December 2nd, not December 16th. So it's troubling that immediate jeopardy involving fire response came up, although it's good to hear that CMS has accepted the plan of correction on that particular immediate jeopardy violation. You shouldn't be having any violations if you are actually trying to get recertified. That's ridiculous. The staff should be doing a better job to avoid any chance that you'll get in that immediate jeopardy, since that could terminate the entire settlement agreement. The regulatory affairs report also mentioned the 3 plans of correction on patient care policies, on nursing services violation, and on a patient rights violation. Those 3 violations occurred repeatedly prior to and on April 14th, when CMS decertified you. You should not be having the same kind of survey violations that wound up getting Laguna Honda decertified in the first place. So it's disturbing seeing these regulatory affairs reports continuing to show ongoing problems, particularly around patient care issues. Thank you.
That's it. Those are the only 2 comments that have hands up.
Okay, thank you. Let's see, commissioners. Commissioner Chow.
Yes, thank you. Actually, my question actually sort of fits into where public comment was. Uh, in the surveys that we are undertaking, because I would imagine the state needs to clear all of these in one or another way, are there and you're submitting corrective action plans as required, or are these kind of in sync with what we already know, or are new things being found that are you know we we've got several hundred of these already. So I'm assuming, I'm hoping that you will say that these are actually items that we are now already in the process of correcting. Would that be, not necessarily specifically, but is that sort of the sense of where you're getting all these, or are they looking like they're uncovering new things that we should have known 12 months ago, and are not part of the current RCA?
Right. So these are reflective of old cases. So for those 3 cases, I believe actually all 3 occurred in 2021. So they are not new issues. So there are instances in which CDPH might call and provide us with a verbal outcome of deficiency to which the facility begins immediate action in correcting, but we don't receive the official document for several months, which then is what we have to follow up with the formal plan of correction. So there are instances where the facility already knows and has already done the work or doing the work to respond to the deficiencies noted.
Well, I guess my question was broader, which was that within our, approach towards the RCA and the milestones, do many of these actually fit into that? And trying to see if we've kind of, with a $1 million evaluation, is the old material that they've also looked at, showing up other things?
So there are, and I'll look to Roland to help me a little bit as well, given the RCA, but these topic areas, yes, do come up in the RCA, right? Our policies, resident rights, nursing services. And yes, the QIE and HSAG did review our deficiency statements. I believe I provided them back to 2021. So they are aware, and they did do that review as part of their RCA. And now we see milestones within our action plan that do address these items.
Yes, and I just add, so again, these are not items that are new to us. I mean, we've done a lot of discovery since April of 2022, and I would say nothing that you see in the action plan or any of the newer documents are things we were not expecting to see, and they very much reflect the initial. You remember the consultants when they started back in May actually did some initial assessments and findings. And so those have been consistent throughout and are still reflected in the most current documents.
Okay, no, thank you. I think it goes back to Commissioner Guillermo's point, was that if the state had been somewhat more diligent or able to actually look at some of these complaints even earlier, we could have been even more on top of the issues that were arising. But thank you very much for your response. I don't have any other questions.
Okay, I don't see any other hands, and thanks for making my point again for me, Dr. Chow, that it looks as if they're accelerating their catch up, but we were 2+ years behind in even the start of investigations just as recently as a few months ago. So hopefully we will continue to note that whatever has been reported and investigated coincides and fits in the overall framework of the action plan and all of the improvements that are being made and reflected in the policies and procedures that we're going to be talking about next. So thank you for that. Since there are no other questions, we can, Mark.
Sure. I'm going to clear the hands for the folks on the public comment line. Item 8 is Laguna Honda Hospital, our Laguna Honda hospital policies.
Okay.
Yes.
And before we get to this, I just wanted to, since this was originally set up for as an item to be voted on by the JCC in terms of recommendation to the full commission, given the overwhelming volume of the new and revised policies, which, by the way, reflects I don't know how many hours. I mean, I can't even imagine how many hours of work, because it's the annual revision in addition to revisions and new policies reflecting phase 3. I just want to thank you for that, but also to note that in order for this body to do the appropriate job and in terms of our responsibility to review and recommend anything to the full commission, we're really going to need additional time to do that. So we will not be taking a vote today, but we'll be bringing, we don't want to delay it, but we're going to be bringing the whole item to the full commission next Tuesday for approval, as opposed to doing this two-step process. And so we will take as much time as we need today for this, for the committee to review, ask questions and so on, but also take the rest of the week for us, as well as the full commission, to review the, I think, what was it, 500 pages or more? Yeah. And I don't know how many hundreds of policies, but maybe that's no here or there, because we just know it's a lot. Okay. So I don't know who was going to introduce. Was it you, Roland, or Naz? You were going to?
No, I will go ahead and do that work. And I will share a breakdown of how many individual numbers so we can understand the breadth and scope. So again, good evening, commissioners. I am here to share with you the policies and procedures that Laguna Honda has reviewed, revised, and created in support of the services and work we provide for our residents here. For the month of December, the facility submits 88 policies. Of these 88 policies, 39 of them are related to phase 3 revisions, 25 of them current policies that have been revised, 14 of them new. So new required policies from phase 3 that went into effect in October 24th of 2022. Additionally, there are 42 departmental policies for your review. 2 are being proposed for deletion. For the month of January, we're presenting 37 policies. There is one policy in this batch that's actually related to our first monitoring survey. So part of our plan of correction there that the facility is bringing forward. 34 facility-wide policies that are being revised. 3 departmental policies, 2 revised and 1 for deletion. And I'm happy to do my best to answer questions that you may have from your review, and also hope that my colleagues on the line can address questions as well.
Okay, thank you, Naz. Mark, see if you have any public comment on this item.
Sure. Folks on the line, again, we're on item 8, Laguna Honda hospital policies. Please press *3 if you'd like to make a comment. I see one hand. I see 2 hands. Caller, you're unmuted. Please let us know that you're there.
Oh, hi, this is Dr. Palmer again. I have some experience in nursing home policies, so I did review them. And one of the things that's really making me nervous is contradictions in the policies about illicit and unsafe substance abuse. And there's one policy that actually says that people who are known to refuse to stop using illicit substances unsafely and will do so in the facility can still be admitted, even though other policies say that it's illegal. And and I really think if the illicit substance use documentation is not cleaned up, you're going to be right back from where especially if people behave according to the policy, you're going to be right back where you started with ODs and contraband. And so please look at those policies. I've written you the ones I'm concerned about. I'm afraid it's an accident waiting to happen. Thanks a lot.
Thank you for your comment. We have one more hand. All right, caller, please let us know that you're there.
I am. It's Patrick again.
Okay, you've got 3 minutes.
Okay. It was inconceivable that the three commissioners could review each of the 123 policies and procedures. After all, they engulf 619 pages that are posted on the Health Commission's website. That's a prohibitive amount of reading for any health commissioners. You should have scheduled a special meeting as a 2 or 3 day retreat to review these policies. After all, those phase 3 regulations went into effect 3 years ago in November of 2019, and you've had plenty of time to have revise those policies, and you shouldn't need to be presenting 89 of them or 88 of them in one fell swoop. I was concerned Commissioner Green had raised a question about whether EPIC could help somehow with the policies and procedures, but Commissioner Green incorrectly stated that EPIC came online in 2021. That's wrong. EPIC came online on August 3rd, 2019, 2 years earlier, according to a press release that DPH had issued saying that EPIC went live department-wide way back in August of 2019. Notably missing from these policies is nursing policy D .1.0. There is the restorative care nursing program that is of keen interest to both CMS and the U.S. Department of Justice. Why isn't D.1.0 included? And does the page 3 guidelines affect that nursing policy D.1.0? And when are you going to consider at the commission any revisions to that restorative care nursing program? It's still inconceivable that you will be able to get through reviewing all of those 123 policies in the next week before presenting a full recommendation to the full Health Commission as early as 7 days from now. So good luck trying to wade through those policies by next week. Thank you.
Thank you. That's the last comment, commissioners.
Thank you, Mark, and thank you for your comments. I will open this up to members of the committee, the JCC. Any questions or comments that you have? Commissioner Chow.
Yes, I did have a few, and some of them I will submit, just putting on the record here. But I do think, and whether they want to answer the general question that I think was raised and is continuing to be raised, is how we are dealing with residents who already have substance use issues and mental health issues, and therefore, in accordance to several of the policies, they either are or not really permitted. And if they are or not permitted, then what do we do when we find them and they're not supposed to be here, or that resident should not be here? Also, I think then separate from those who are currently here, what is the policy about how many of that is, what is the policy about people being admitted in the future, because I do think that some of these policies are not clear. If uh, I'm sure that you've written them so that they are consistent, but if they are, the way that they're read quickly, and I must say that over the weekend I didn't realize it's 500 pages, but I, I've gone through almost all of them, certainly, on a high level, with the help of your explanations in terms of what each of the policies were being changed for or being added into. Uh, on the surface, they appear contradictory. So I would think that what we need to clarify is how people get admitted, and what if they already are using a illicit substance and do not intend to stop, or are they going to promise stopping before they get here? And what do we do for the people who are already here? And part of your policy says that's not a reason for discharge from the hospital. Of course, they have to be safe enough to discharge, so that's another dilemma. But then there also is another statement that says that uh, none of this then takes away from the rights of law enforcement to do something. And if we put that statement in, what does that mean? Do we say that our staff doesn't do anything, but we will let law enforcement know? But if we're not going to be a law enforcement uh, agency, then letting them know actually, sort of acts on their behalf, or perhaps we're not. So, not exactly sure, but just want to clarify, what do we do with people for admission, and what do we do for people with these issues of substance abuse or difficult mental health needs that would then be here and then not be, found to be in compliance?
I'm happy to start. And then, I see that Lisa Hu and Daniela Kim are on the line. And I understand and acknowledge that there's concern that the policies are contradictory. I think the big thing to note is that these policies are not mutually exclusive. So, for instance, the policies around, let's say, harm reduction or behavioral health services, this is the type of environment we aim to provide, and the type of quality of care services that we have on site. Given that the regulation stipulates we cannot deny admission to someone solely because they use substances, right? So if there is an individual who meets the criteria that the facility feels that it can provide services for, we then admit those individuals. And I'm sharing of current state. And so those policies are speaking to those processes and the work that we do. The policies around clinical safety searches, or for example, we have a policy around illicit or diverted paraphernalia, drugs, so forth. Those are when we have individuals here and there are challenges being presented, right? They are potentially creating an unsafe environment for themselves or others. And when we are in those situations, there are sections of the regulation that do permit us to then potentially discharge those individuals because of the health and safety risks they pose for the facility, for others, and for themselves. In regards to the new phase 3 regulation that now says that staff are not to act as an arm of law enforcement as it relates to searches, right? And that if there are to be searches done by staff, they are to have consent from the person before conducting any search. So it is not to say that Laguna is going to become a law enforcement facility. We do have the sheriffs here on site as our security, but our goal is to provide a home-like environment for all our residents here. And so we need to be mindful of that regulation and do our best at the same time to provide a safe environment for everybody here. In regards to, more detail around the behavioral health services and the work that the folks are doing, I want to acknowledge that Dr. Yifeng Chen is not with us on the line, but I will look to my other physician colleagues who are on the line if they want to share any additional details.
Hi, thank you, Noz, and good evening again, everyone. I think I would just like to add this, that we acknowledge that the primary criterion for Laguna Honda is, do you have skilled needs that we can meet? And the other problems, the other challenges that come with people that we admit, we try to address them. And one of them, very frankly, is substance use. It is pervasive in the community. So we would not consider that Laguna Honda would be impervious to these, would be excluded from having residents that need our care who also have substance use disorder problems. And we take a harm reduction approach here as best we can. And we have one of our behavioral health psychiatrists has expertise in substance usage and addressing that. And we make very liberal use of his services. I know that there was that hundreds of people have been referred for substance use programs here and substance use interventions. And our behavioral health colleagues have done an amazing job seeing all of the people that have been referred to them. And there's a whole spectrum of services that people will participate in and will not participate in, but the offer is there. We have groups here for people to participate, including drop-in groups where we try to meet people's needs, and some people don't want an appointment. Some people are not able to keep those appointments and have that kind of structure. So we have a drop-in group for people. But we also have structured groups for people to participate in. We have one-on-one. And so we try our best to address this in a harm reduction way and in a way that can meet the needs of our residents, meet them on their terms so that we can make inroads on helping them. And so I think that's all I can add and contribute to all that Naz has said.
So I'm wondering if you would clarify then for all of us that the new regulations say we specify that these people who may be using substances are not to be excluded based upon that. Is that the CMS phase 3 guideline regulation or whatever we call it?
I can't recall if it's part of phase 3, but there is a regulation in which you cannot deny admission solely on the fact that somebody is an active substance user.
And it would be helpful, I think, if we were able to just see that,
Sure.
so that we can sort of clarify. I thought it was very good that you talked about these not being mutually exclusive. How do you then reconcile the question of uh, having found or suspected illicit use, that you don't act as an extension of the law, but that at the same time the law can be actually doing its job?
That's a good question. So given the new regulations and guidance, so if staff are to suspect an individual of active substance use or being in the possession of illicit substances and or paraphernalia, they should then come together as a care team to discuss potential interventions or increased monitoring of the resident for their safety. Additionally, if they see anything in plain view, meaning if it's right on their person or right on the dresser or the bed, they are able to confiscate it. It is permitted to confiscate the items if you can see them in plain view. That could be so much as, your bag is open on the table and I can see right in there that you have something. The facility and staff partner with our security team here on site if there are any instances or moments in which they feel that they are in an unsafe situation, if there is escalation of behavior and or they need support. And so they really work to partner with the security teams here in promoting a safe environment for all the residents and the staff. I'm not sure if Terry wants to add more in terms of how I know nursing is doing a lot of work to improve relationships and partner more with our security teams here in support of the facility and the residents.
I don't think I have anything to add. I think you covered it really nicely. Thank you.
Yeah, I'd like to add a bit if I can. So, thank you, commissioners, for raising these questions because they really reflect the reality of particularly the introduction of these new phase 3 requirements from CMS, because unfortunately they do present a challenge because on the one hand, the new requirements clearly require that individuals who have mental health and substance use issues, you must provide the appropriate care for those individuals. They also prohibit you from excluding those individuals from admission to the facility. At the end of the day, it comes down to appropriate care planning on an appropriate individualized care planning for each individual as their presentation with either mental health or substance use issues is variable and very much specific to that individual. The rules also state that the institution must take appropriate actions to ensure that individuals are not a safety threat either to themselves or other residents. So the policies, while they appear to be conflicting, have been drafted and approved through our legal counsel to be compliant with CMS regulations to address those various components, not excluding individuals with mental health and substance use diagnoses, but also ensuring and also not allowing searches that for which residents or their decision makers do not agree. So there's this delicate balancing act, and it does give the appearance that there is conflict, but we're balancing different elements. The needs of patients from a medical perspective, but also from their perspective of the rights that they're entitled to and safety of the residents and the institution itself. I will note that the admission criteria for Laguna does state that individuals who are in active mental health or substance use crisis are not eligible for admission to Laguna. And I think that's appropriate because Laguna is not set up for mental health psychiatric crises. It doesn't operate a psychiatric emergency system. It does not operate illicit substance detox, so it cannot appropriately care for individuals in crisis. But in terms of individuals who have a history and are stable, then yes, we are expected and are required to provide those services as a CMS participating entity and be prepared to sit for our survey based upon having policies that do not exclude those individuals, but at the same time balance safety and care.
Well, thank you for both of you, especially to try to clarify what is a potential conflicting situation. But at least for me, it's helped understand how the regulations are asking that we write the policies, which I'm assuming then the policies also had the assistance of our consultants. So this seems to mesh with how the consultants feel that we can meet the regulations and respond back to the RCA, I guess. Would that be fair?
Yeah, absolutely. Our consultants did consult on all of our policies, in particular the new phase 3 requirements.
Okay. I had a number of other very short things, and I think what I will do, because most of them can be answered quite quickly offline, actually, and rather than taking up the committee's time in terms of some small issues. The only large one might be that you do have an antibiotic and stewardship committee, but I did not see, and perhaps you want to see that since you're advocating that, or actually adding an infection preventist, that as I read the committee, it didn't seem to say that there was that position would be part of the committee. But from a substantial, input standpoint, I would think that would be helpful. But I'd leave you to see that maybe I've not read it quite correctly at this level, and the remainder I'll just submit to you as some less important questions.
No problem. And yes, thank you for, we will double check that on our end. The infection preventionist is definitely part of that committee.
Okay, thank you.
Okay, thank you, Commissioner Chow. Commissioner Green.
Yes, well, I'm 20% through, and I also will maybe send some written questions. I had some about the infection preventist as well. I want to make sure I understand just about the residents we do admit to Laguna, because the San Francisco population is clearly aging, and if, God forbid, we end up with a bed limitation, despite all of our efforts to the contrary, are there certain primary diagnoses that you prioritize? I mean, we talk about admissions, and obviously they're on hold now, but maybe that gives us an opportunity to better think through the patients and the residents that would be best served by the services we can provide effectively and have been able to demonstrate we provide well over many years. So I would assume that substance use disorder or behavioral health problems are by no means the primary diagnosis that would admit anyone to Laguna, that it would be a secondary diagnosis. And that's correct, isn't it?
Yes, as Dr. Hu said, the primary diagnosis has to be that of meeting criteria for skilled nursing care.
Great, and I know we've improved our list of diagnoses, so it's better, it's more easily understood what has brought the residents to Laguna. So I think, yes, we probably will have some more detailed questions in the future, but I would be curious at some point to learn more about the thinking for admission, or if we can even find the where our residents come from, over time, what our expectation is. And then the other question that I badly asked earlier was, where are these policies posted? Is there an intranet where someone can go? Is it where would a staffer that wants to say look at some? I know that restraint definitions, for example, are complicated, and I'm wondering, as are some of the harm reduction. There are quite a few definitions which are very helpful, but I wouldn't want to take a quiz. So where would people find these things?
They are all posted on our intranet. So we do have a Laguna Honda intranet page that all staff have access to. And there's a very long hospital policies page as well as departmental policies.
And categorize kind of like, in other words, is what we got about what's a new policy, and what is that part of your page so that people can find it?
Not to that extent. We do communicate out in our what we call our daily situation status communication, so staff can see that summary list of new, revised, deleted. When you go to the page of policies, it's broken down by subject area. So daily care management or infection control or quality assurance, that sort of thing. So by subject area, and that's how you see those different numberings. The numberings on those policies are associated by the group that they fall under.
Great. Well, thank you for that clarification. This thing has been really helpful understanding what's phase 3 and what's new, and very helpful. So yeah, that was the only questions I had, and I'm plowing my way through it. It's interesting.
Thank you very, very much for
experience and a lot of work. I don't know how you managed to do all of this, especially because a lot of it's de novo. You didn't just pull it off the shelf from someone else's. There's not much plagiarizing there that I could find. So thanks.
Madam Chair, I just wanted to ask in terms of its usefulness, because there's great definitions and discussions like about scabies and all. Is there an index that if somebody thought they had a patient with scabies, they could then look it up rather than just knowing the number?
You can search the site. Yes, you can search for keywords and it will bring up the policies.
Okay. No, terrific. Sorry to.
No, good question.
That's okay. That was actually going to be part of my comment or question, is that it's a searchable database posting within the intranet as make it sort of easily referenceable, by keywords or what other criteria. So glad to hear that that's the case. And also, I want to thank my fellow committee members for what you've done to date in being able to peruse from a general sense and then dive deep into the detail of the policies and procedures, because clearly, even though the rest of the commission, the other commission members are getting that the same as of today, they are going to be depending on us to probably assuming in our meeting today that the deep dive being done either through sort of an offline set of questions or through today's meeting are really sort of taking into consideration the kinds of things that they would also be asking about. And we will have the opportunity at next Tuesday's meeting for any additional questions and insights that might need to be brought forward. But today was really sort of the intent was to try to sort of uncover as much as we possibly can in the time that we have allotted, and then provide for the rest of the week for thoughtful consideration. So thank you very much. And then also to just reiterate that this is a body of work that has been in many instances, not just, in the making in the last, few months, that has actually been something that's been in the making for quite a while, knowing that the phase 3 regulations have had been released, but not necessarily been surveyed, not the basis of a survey until recently. So thank you very much for all of that work for the annual review, as well as for, as it's been referred to, the de novo construction of all of these policies. I'm sure that there's going to be some opportunity to and some need to review them again more so as we begin implementation and actually get surveyed relative to them. Aside from the need to implement them with regard to our recertification. So thank you very much, and look forward to any additional comment and questions that'll come over the course of the week. I think, Mark, that concludes the regular open session on the agenda. We still have some items to discuss in closed session.
Yeah.
So can you lead us in the right direction?
Absolutely. Item 9, is a consideration for a closed session. And the first part of that is taking public comment on the closed session. Actually, folks on the line, I didn't clear the hands. So I see 2 hands now. I'm going to call you both. But folks on the line, if you want to make comment on the closed session, this is the time to do so. You can press *3. And again, I'm going to call on the 2 folks who already have their hands up. Hi, Dr. Palmer. Would you like to make a comment on this item?
Hi, yeah, this is Dr. Palmer. I'd like to remind you that as far as I can tell, the public does not have any access to the root cause analysis, the revised closure plan, or the action plan. And so you're essentially talking about stuff that you haven't let us stakeholders who may someday need a bed at Laguna Honda see. And this seems kind of unethical to me. Thank you.
Thank you for your comment. Mr. Manette Shaw, would you like to make comment on this item?
I would, Mr. Morowitz. Thank you.
Okay.
The closed session is also considering a quality improvement closure plan update. As you go into closed session, I want to thank the commission for your work around the policies and procedures as Laguna Honda's governing body, that's your duty as a ministerial duty to review those policies and procedures, especially around, especially since recertification is at stake. I want to repeat testimony previously made today by a number of people that because the closure plan you may be discussing in closed session does not yet have a provision that CMS is approving extending the pause on discharges, that the commission needs to collectively try to encourage the city attorney to complete writing that request to CDPH about getting the extension on the pause as quickly as possible. We shouldn't be running up until February 1st before we learn whether that pause has or has not been extended. You need to be giving more notice to Laguna Honda residents who may be facing those discharges. So please, in closed session, do whatever you can to get the Health Commission to take a formal position requesting both that the city attorney expedite getting that letter sent off and involving the Board of Supervisors on getting their assistance in getting that pause extended. It's critical that you guys take the effort today in closed session to ensure that pause actually gets extended. Thank you.
Thank you for your comment. Now, folks on the line, you may know this, but as the committee goes into closed session, you will not hear or see us, but we will come back after the closed session and adjourn the meeting, so you're welcome to stay until that time. Commissioners, this is now a time to consider a motion to go into closed session.
Thank you, Mark. Okay, we have a motion, and do we have a second?
Second.
All right, I will do a roll call vote. Commissioner Guillermo,
Yes.
Commissioner Green,
Yes.
and Commissioner Chow.
Yes.
All right, please give me 30 seconds to move us over. And again, members of the public, we will see you in a little while. open session. Commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
Okay, is there a move not to disclose?
Move
Or
not
to
to
disclose or not to disclose, sorry.
Move not to disclose.
And I would second.
Roll call vote. Commissioner Chow?
Yes.
Commissioner Green?
Yes.
Commissioner Guillermo?
Yes,
All right, yay. So now we're at a consideration for adjournment.
please, and may I have a motion?
I
Nobody
move
wants to adjourn?
I heard enough. Commissioner Chow?
Yes.
Commissioner Green?
Yes.
Commissioner Guillermo?
Yes.
All right,
And
thank
now,
you all.
now I can go meet with my neighbors to talk about all the leaks that are happening in our building. So sorry, that's why I was in such a rush, but yeah.
We'll write you an excuse.
Thank you.
All right, thank you, and everyone.
Take care,
Happy, healthy
everyone.
New Year. Take
Stay
care.
safe.